Good morning, everyone. We begin today's session with Dr. Kiran Shandilya and Dr. Leena Bhagat. It's an interview session. I would like to introduce Dr. Kiran Shandilya, MD, DPM, gold medalist psychiatrist from Grant Medical College, experience in psychopharmacology and psychotherapy. Works in the field of child psychiatry, women's psychiatry, and yoga therapy. Proven history of the combined use of traditional psychiatry, use of yoga and spirituality in the treatment of mental health disorders. She's the owner of Dr. Kiran's Mind Center, a holistic treatment center in the field of mental health. Consultant psychiatrist at Sion Hospital, Mumbai, and ex-assistant professor in Grand Medical College. Awareness programs in association with Radio Military, Care TV, various newspapers and TV channels to reduce stigma in psychiatry. She has done awareness programs in various schools and colleges with students and parents for psychiatry awareness. Dr. Leena Bhagat. She will be interviewing Dr. Kiran Shandilya. Leena Bhagat has done her MBA, BS and DA from St. GS Medical College. She's practicing in Borivali for 30 years, now shifted to Vilepale. She was GPA GB coordinator of Borivali branch for 12 years and arranged various lectures. Now I hand over the mic to Dr. Leena Bhagat.
Hello. Thank you, Dr. Bhavini. Good morning, Dr. Kiran Shandilya. So let us start with addiction. So which are the red signals which point towards a person being an alcoholic rather than a regular drinker? And are there any lab tests to help establish the diagnosis?
So good morning, Dr. Leena, and a special good morning to Dr. Preeti. Thank you for having me here. And it's nice to be back at GPA.
Mic is up. It's working.
Is it better now? Huh. So you're talking about lab tests for addictions. Actually, what is very important is just questioning about addictions and assuming that there's an addiction rather than otherwise. So they're very simple questions that have to be a part of our daily history taking with each and every patient. Rather than saying, do you drink, we have to say, how much do you drink every day? We assume that the person drinks. How often? What is the quantity? Similarly, about smoking, how much are you smoking? Are you on any other substances? Specifically ask about ganja, weed, marijuana, because these are extremely commonly used for recreational purposes. Those of you living around this place in Juhu, there's a lot of film industry, television industry, and it's extremely rampant there. It's not even an expensive addiction. Other than that, we have urine drug screening tests that are commonly available in labs. It's a small cassette kind of a thing, very similar to how you have a urine pregnancy kit. And you have a 6-drug panel and an 11-drug panel. A 6-drug panel should be quite good, but where we are using urinary drug kits are basically for patients who are suddenly have an accident and we don't know, or patient is unconscious and we don't know if the person has been using. Normally history taking suffices and ask family members.
How does joining AA help? And can you tell us about the various rehab groups and how to choose one?
So Alcoholics Anonymous has been an established program made by the ex-alcoholics themselves who encourage others to get out. They have a 12-step program. I think it keeps the motivation high of a person. But within Alcoholics Anonymous also, you have those who are extremely motivated and do very good work, especially those that are working in established centers over a period of time. But they are the lesser known people also, who, they have a negative kind of an outlook. And they may actually introduce the person to drinking back again. So what I feel is that Alcoholics Anonymous is good, but it's not the only thing. What is required is clinical treatment. So clinical treatment in alcoholism is divided into 2 parts. One is the withdrawal management and second is the relapse prevention. So along with that, Alcoholics Anonymous is good. But just Alcoholics Anonymous may not suffice for a chronic alcoholic. You're talking about rehab centers. I feel that's a very, very good question. So any rehab center that has a psychiatrist attached to it is a good rehab center. Why I'm saying this is because there's a proliferation of rehab centers. And there are rehab centers that have no doctor attached to them, that are made by ex-alcoholics because they just understand the procedure and they realize it's a lucrative business. They are made by ex-policemen who have sort of understood it's just a hall जिसमें लोग बंद हैं. They are eating food. There's no access to alcohol and other substances. Other than that, there is no form of treatment. In the best of these centers, there's no form of treatment in terms of medication, in terms of counseling, psychotherapy, whatsoever. In the worst of these centers, people are extremely poorly treated. They are beaten up, they are made to do jhadu pocha, kapda, and their way of dealing with an alcoholic is punishment. So the problem is that these centers are a lot cheaper than centers that have a doctor attached. So a center that has a doctor attached may have a monthly cost of 25 to 30 on the minimal side, where some of these centers may be available for 10 to 15,000 a month. So a lot of parents, they just figure out ki falane ne bola and they just admit, and actually patients come out worse from there, very angry.
So how does a family practitioner anticipate and manage withdrawal in an alcoholic patient?
So I think if the history is established that this person has alcohol, we have to suspect a withdrawal. For example, you're starting any form of treatment for your illness. Let's say you're treating malaria. Now, if you're giving clear instructions that you're not going to be drinking with these medicines, you would probably have to give him a benzodiazepine along. So you have to tell him that I'm giving you something that you will not go into withdrawal. Also give thiamine. So the most important parts of withdrawal management are vitamin supplementation, specifically thiamine, because they are very deficient in vitamins and they may actually go into a Wernicke-Korsakoff's encephalitis. Now, the other thing is that other than vitamin supplementation, we will have to give them a benzodiazepine cover. Usually a long-acting benzodiazepine like chlordiazepoxide, diazepam are good provided a person's liver parameters are not very deranged. If the LFT shows very high liver GGT, etc., then probably you need to go to lorazepam, which is only got a renal clearance, does not interfere with the liver parameters. So we have to preempt and give multivitamin supplementation and benzodiazepine cover because some of these people may have seizures on withdrawal. So during the lockdown, there were a lot of people who broke down into delirium tremens, psychosis, seizures during the withdrawal phase because it was not available.
What is the GP's first tool for tobacco de-addiction and how does he monitor such
So
patients?
again, ask and encourage a person to quit. That is the most important thing. Tobacco has a lot of behavioral role. See, Wernicke is not a drug that can be easily prescribed by a general practitioner, nor is bupropion, because there are certain side effects or certain kind of a management profile that will not suit each and every patient. So I feel at a GPA level, we can do replacement with nicotine gums or nicotine patches. But the behavioral part is very important. So what I tell a patient is, कि आप छुट्टा cigarette लेना शुरू करो. So instead of buying a packet, they buy one cigarette at a time. That in itself reduces by, let us say, 30% तो वहीं पे कम हो जाता है. जो erroneous cigarettes we keep, our go-to stops, that is one. The second thing is we ask them to maintain a log. Cigarette अंदर गया और क्यों गया? Is there a genuine craving or are you bored? Are you brainstorming about something? So what happens with addiction is लोगों का repertoire of behavior becomes very narrow focused. In the sense, खुशी मनानी है तो with addictions, दुख शोक मनाना है तो with addictions, problem solving करना है तो with addiction, relax करना है तो with addiction. So we give them an alternative behavior. We also tell them to replace this with something else like chewing gums or soft, aise kuch, so that they can get away. But reduction and nicotine replacement in the form of patches, etc.
Now coming to OCD, which are the various types of OCD, which are the high-risk groups, and how does a GP suspect OCD?
So the common varieties of OCD, we have the varieties. So OCD is a complex of having an obsession, which is an intrusive, recurrent, persistent thought, and an obsession, which is a compulsive behavior. Sometimes the behaviors are physical, and sometimes they are mental behaviors like repeating words or praying or counting. So OCD, contamination OCD, where you have a doubt that something is contaminated and you keep washing, cleaning, those rituals are very common. The checking OCDs, where you have a fear that something you've done may go wrong. Like for example, gas on chhod diya, ghar ka tala khula chhod diya, gas ki chabi lagi chhod di, sorry, car ki chabi, ATM ke upar password chhod diya. And constant checking, rechecking, going again and again, switching on, switching off, locking, unlocking, those kind of things. So there is this OCD. Blasphemous OCDs are very common, anti-God feelings. So most of these people are highly religious people. Like I had a Jain woman who was 60-year-old, and she had, jab Bhagwan ki puja karne baithti thi, she used to get gali in her mind. Okay? Or she would get a sexual imagery in her mind. And as a penance, wo aur fast karti thi aur puja karti thi. And she would not share this with others. That what they said is, ye khana khati nahi hai, she's become highly religious. Can actually a treatment be available for this? Then I had a Maulana who had this urge to go on the mic, jab wo azan padhte hai, to go on the mic and give a gali. And he couldn't share this with anybody else because he was teaching children. Okay, so you have these religious blasphemous OCDs. They may be inappropriate sexual OCDs, where you don't want to have those OCDs. Like for example, there's one which is a sexual fantasy that a person may enjoy indulging in. But I had this 7-year-old child coming with repetitive bad thoughts of women kissing. So he would not look at his school teachers, he would not look at his mother, sister, would stop going out to play. So those kind of OCDs. So essentially a person comes to the clinic with a lot of anxiety, withdrawn behavior, repetitive behavior. In the US, the lag between development of OCD and seeking clinical help is 10 years. We don't even have a statistics in India. In psychosis, the lag is 2 years, but in OCD, that much is the lag. So these are the common OCDs.
Would counseling help, and when should you refer?
So OCD has a very specific form of counseling called exposure and response prevention. It's a form of cognitive behavior therapy. It helps, but it has to be done by a trained counselor, and not all counselors are trained in this form of counseling. So every form of, like for example, hypnosis will not work in OCD.
Okay, so you need special.
You require that form of counseling. So it is best, and then that counseling has to be done over 12 sessions, one hour session each, every once a week or once in 10 days. So it's not something that can be done in a clinical practice. I wouldn't take it up because it will be that much time taking. I would delegate that to somebody else.
Okay, ma'am. How does a GP approach chronic medically unexplained symptoms like headache, backache, or fatigue?
So this, I think, Dr. Leena, is a very, very vital question, because they say 1/3 of patients suffering from any chronic complaints probably have an underlying depression, anxiety, something. And these are complaints that will frequently come to you in the form of various aches and pains. She said headache, neck pain, backache, in the form of just fatigue, ghabrahat, even white discharge, tingling, numbness, all these chakkar aate hain, all these kind of vague complaints, and you have done all investigations that have proved. So first you do what you're supposed to do, as in evaluate the person physically and rule out any other causes that may be present. Like chronic pain, you may want to rule out rheumatoid arthritis or whatever it is. Once you notice that after this also there is no obvious cause, it will be worthwhile doing a psychiatric interview of the person. Asking since when is the pain, how long is the pain, what are the precipitating factors, are psychological factors precipitating factors. So for example, झगड़ा हुआ उसके बाद चक्कर आता है और बेहोश होते हो, या सीढ़ी चढ़ने पे चक्कर आता है और बेहोश होते हो. You know, they're two totally different things. So I think focusing on psychological, directly ask the patient that क्या आपको मन में उदासी, घबराहट अक्सर रहती है, नींद कैसी है, भूख कैसी है. These are easier questions to ask. I think directly ask the patient and give the person some alone time. Ask the family to leave and say, is there any stress you are going through? Okay. So what I remember when I was doing my internship in Sion Hospital is that we used to treat these patients with a lot of anger, irritation on our part. We used to say, ये सब नाटक करते हैं. This is when I was doing my internship, MBBS वाला. Of course, things changed when I was doing psychiatry. कि ये लोग सब नाटक करते हैं, ये ड्रामा है, कुछ भी नहीं है इसको. And we would just dismiss the person. But this person is constantly complaining of pain, or we would say this is attention-seeking behavior. But I think it's beyond attention-seeking. Like I had this one lady, she would have these pseudo-seizures. And I started talking to her and she said her husband is an alcoholic. He beats her up, and after she started getting the pseudo-seizures, he has stopped beating her. So the pseudo-seizure was actually serving a purpose. So something like that, you know, if we can find out, then probably these patients would really benefit with addition of antidepressants, specifically in pain symptoms. We require antidepressants that have a norepinephrine compound, so maybe amitriptyline, nortriptyline, these may be better compounds than just SSRIs. Another problem is that sometimes there's no you have a psychologically well-adjusted person, but that person may have a signaling problem. What do I mean by a signaling problem? Pain is supposed to be protective, especially acute pain. जैसे कुछ चुभा और हमने पाँव हटा लिया, so we know कि it's a protective mechanism. Or we have a fracture and we have a lot of pain, we'll immobilize the joint and it'll get healed. So acute pain has a protective reason. Chronic pain may be because of inflammation like arthritis, etc. Or chronic pain may be a signaling problem where there has been a nerve injury and the nerve injury is just oversensitive. You know, like let us say how we think of a phantom limb pain. Or it could be a brain being over-receptive to pain symptoms. So even when a person is not supposed to perceive pain, the brain is perceiving pain. At the end of the day, the brain is the perceiving organ. It is not the peripheral structure where the pain is happening. So specifically norepinephrine, anything that has a norepinephrine component tends to dull the pain a lot better. Of course, we are also using pregabalin, gabapentin, all those in pain control. So duloxetine, for example, is being used by a lot of orthopedic surgeons. Again, because it has a pain relieving component.
What are the symptoms of major depression and for what duration should they be present?
So again, coming to this point that it's so important to understand depression. According to statistics, we are one psychiatrist per 25,000 patients. So there is no possibility that psychiatrists alone in India would be able to handle depression. So countries like Australia, US are short-staffed for psychiatry. So India, though we are a far cry. Which means a lot of depression will actually come to the offices of general practitioners and every other practitioner, whatever field that you are in. So understanding and the ability to treat basic depression is very important. As important as we know MI and as important as we know almost everything else. So another thing is this is a disease that affects 10 to 15% of the population. So it's more common than diabetes and blood pressure and everything because they're not present in 10% of the population. It's a very, very high number. The symptoms are very simple. There are 9 symptoms. First symptom is a chronic feeling of sadness. Sadness that doesn't change. You have a positive event, it doesn't change. A feeling of total loss of interest. मन ही नहीं करता, मुझे गाने सुनने अच्छे लगते थे, मन नहीं करता, फैमिली इकट्ठी होती थी, पिक्चर देखने का मन करता था, मन ही नहीं करता. Even things that I used to enjoy, children stop playing, stop connecting with friends, you know, like that. Then you have body-related symptoms. Hello? Huh. Sleep deprivation. So mostly sleep deprivation, but sometimes you can have hypersomnia also. Similarly, appetite-related changes, mostly loss of appetite, but sometimes they can be a hyperphagia also. Usually adolescents show this reverse symptoms. You can have a feeling of a lot of fatigue, unexplained fatigue. A person may actually visibly look slow, psychomotor retardation, like how a person with Parkinson's walks slow, talks slow, does not show facial expressions, has an increased latency of response. Very similar we may see in depression, that kind of a retardation. They complain of concentration memory problems. So they often say that I've become very forgetful. Like women say, I've been cooking all my life and हम लोग कभी खाना चखते नहीं हैं. But I have to taste कि मैंने नमक डाला कि नहीं because I tend to forget. Okay? There can be inappropriate negative thoughts. I am good for nothing. The world is a hopeless place. Nothing in future will ever be good. Life is not worth living. So people can have suicidal thoughts. It will start as a death wish. Life is not worth living. It is better off I die. If it continues like that, maybe I will attempt suicide one day. So gradually progresses from a death wish to a passive suicidal thought to an active suicidal thought that I have a plan. And inappropriate guilt ki I'm not a good mother, I'm not a good father, I am doing wrong to the society, you know, like that. That has no basis to it. So these are the common symptoms. This is available as a PHQ-9 questionnaire. It's online available. Okay? It's a small questionnaire that even can be just given to the patient and patient can fill it up on their own. It's available in all major languages in the country. So this is something that we have to know how to evaluate, and we have to start treating depression. So at a general practitioner level, I feel SSRIs, specifically 3 SSRIs, escitalopram, sertraline and fluoxetine are good medicines. So we have to know these 3 drugs inside out. If we are writing something, we have to know it. The reason is they are very safe in overdose. They have relatively milder side effect profile other than GI, etc. There are no major side effects. And the third thing is that most patients, up to 70% patients with depression, are likely to respond to these very basic SSRIs. You also don't have to escalate the dose, like 10 mg is a good enough dose of escitalopram, 50 mg is a good enough dose of sertraline. So there's no need to, you can start at the target dose. There's no gradual building up. Like amitriptyline, for example, has effective antidepressant usage at 75 to 300 mg. And most general practitioners don't go above 25 mg. So probably we are achieving some kind of migraine control, some kind of control over pain, but we are not achieving an antidepressant limit. So in that term, it's much safer to give an sertraline and things. Then the other thing is, once we have started, so a lot of general practitioners today actually start antidepressants, and I feel it's a good thing because those patients are at least getting treated. We have to reevaluate on follow-up. We have to ask them, how much improved is your depression? How much improved is your sleep? How much improved is your anxiety symptom? Whatever it is that was their complaint. What I find lacking is that they start a sertraline, but they will not reevaluate. Like for any other symptom, we reevaluate कि pain कितना कम हुआ. We will also say depression कितना कम हुआ. So, if we find a person is improving and significantly better, great. And I'm telling you, 70% patients will improve with SSRIs. But there would be patients who are not improving. 30% patients will not. And as you start treating, you'll gain more confidence in it. Those patients need to be referred. Because chronic untreated depression then becomes resistant to treatment, like any other disease. So that. Another thing is general practitioners are very scared of asking about suicidal ideation. They feel it requires some specific training to ask about suicidal ideation. I use no tact in asking about suicidal ideation. Very tactlessly I say, कभी मन में ऐसा ख्याल आता है कि जीने का कोई मतलब ही नहीं. कभी मन में actually आत्महत्या का ख्याल आया है. Very, very simple lines. I'm not even saying by the way, छुपके से, कुछ नहीं. Direct questioning. And patients are very relieved to answer, and we do not increase the incidence of suicide if they tell us. So that is a scare a lot of people have कि अगर कहीं ऐसा तो नहीं कि हमने ही उनके मन में आइडिया डाल दिया. Okay, so basically like this. Secondly, if let us say a person comes with suicidal ideation and you are saying refer to a psychiatrist and the person chooses not to go, at least put it on paper. Put it on paper that patient has reported depressive symptoms, suicidal ideation. I have advised them to go to a psychiatrist. They are refusing. Just put it on paper.
And ma'am, which questions do you ask before starting SSRI so that you don't tip a bipolar into mania?
So one of the screening questions, 2 screening questions is that have you actually have episodes of being extremely happy, overconfident, overspending, online dating, online gambling, over shopping, things that are uncharacteristic of you, and family has said that this is totally uncharacteristic of you. The other thing is that is there a family history of bipolarity psychosis? So if a family history is present of bipolarity psychosis, I would say better not touch that case. Having said that, incidence of depression is 10 to 15%. In a GP's office, it may be 20% of the patients coming for chronic complaints, not for acute complaints, may have depression. However, incidence of bipolar is 2%. So while we have to keep the bipolarity in mind, we don't have to think that every person we start on an antidepressant will switch.
How do you approach insomnia?
So insomnia, again, I think sleep appetite has to be a part of our basic history taking. Then insomnia we divide into early insomnia, नींद जल्दी नहीं आती है. Middle insomnia, नींद आ जाती है लेकिन बार बार जागना पड़ता है. Late insomnia, अर्ली मॉर्निंग अवेकनिंग, नींद आ जाती है 10 बजे, सोने जाते हैं और रात के 3 बजे उठ जाते हैं और फिर समझ नहीं आता कि करें क्या. ठीक है. सो दीज आर द 3 काइंड्स ऑफ, एंड दे कुड बी अ insomnia that's ongoing. Now, early insomnia, we just require a sleep inducer. One of the number 1 problems with early insomnia is a late caffeine use and the mobile use. मोबाइल से डैमेज क्या होता है? एक तो ब्लू वेव के बारे में हमें पता है. दूसरा जो लाइट सिग्नलिंग है, मतलब our brain can adapt to a dark signal to sleep. Sometimes a light constant signal, जैसे धूप में गांव में काफ़ी लोग सो जाते हैं. But a flickering light signal confuses the brain कि जागना है या सोना है, which is why discotheques they use a flickering light. And any screen an hour before sleeping will confuse the brain. So one of the things that you have to tell about early insomnia is that screens have to be switched off 1 hour prior to sleeping. It's a part of sleep hygiene. It's very important. A lot of people have delayed sleep onset and then they are getting up at 9 in the morning, 10 in the morning. Okay? So it's just a part of lifestyle. We say kitne baje neend aati is not in your hands. Kitne baje aap uthte is in your hands. So start waking up consistently early and chances are that you'll shift the phase. For these people, melatonin is a good drug because melatonin acts like a sleep inducer. So melatonin has to be taken 2 hours prior to sleep time. People who complain of early insomnia, we have to evaluate them for anxiety. That are they overthinking, not able to sleep because they're very anxious about something. Middle and late insomnia are often related to depression. So giving them a very low dose antidepressant, like let us say, giving them amitriptyline at 10 mg or dothepin at 25 mg or something like that, will help them with their insomnia without causing a dependence. And without us being very scared about the cardiac side effects, this side effects, because at that dose they really don't have side effects. We can start with the Z drugs, zolpidem, etc., etc. We can also start with clonazepam and these drugs. But remember, once we start a person on any benzodiazepine, on a Z drug, they almost never come out of it. So if it's a short-term duration thing, let us say there's been a death in the family and this person's very disturbed. So there's a crisis situation. We know it's a short duration thing. We can give the drug and we give a tapering dose. Like how we are so careful in steroids that we know that we are giving a tapering dose. I think on paper we put down a tapering dose. And similarly, but there are patients who are taking benzodiazepines for years and they're not escalating the dose. Like उनका 0.25 mg alprazolam या 0.5 mg clonazepam चल रहा है, 15 साल से खा रहे हैं, but tolerance नहीं आ रहा है कि उस dose पे नींद आती है. It's not कि they are increasing the dose, they are shopping about these drugs, they are meeting doctors, they don't have an addiction behavior pattern. It shouldn't be very alarming. We should try and gradually reduce the drug.
Can acute anxiety symptoms be because of vitamin B12 or vitamin D deficiency?
So vitamin B12 and vitamin D deficiency, I think, are overrated in medical things. So they may have a contributing factor, but all of you would know just how common they are. Probably if we got ourselves tested and we are not supplementing ourselves, we would be deficient in vitamin D and vitamin B12. So that being a cause of depression is an overrated thing. Then again, there are people, so even if you believe that and you start B12 and D3 supplementation, after 2 weeks, 3 weeks, it's important to evaluate whether the depression is gone or not. So if it's not gone, probably another treatment is warranted.
What are the symptoms of generalized anxiety disorder and for what duration should they be present?
So anxiety, depression often go hand in hand. Rather than saying generalized anxiety disorder, let's just think about common symptoms of anxiety. So anxiety has physical symptoms, psychological symptoms. Physical symptoms are heartbeat बढ़ जाना, सांस फूल जाना, tremors होना, चक्कर आना. So all these are physical. Psychological symptoms are constant worry, constant seeking reassurance, overthinking, needlessly overthinking, unable to switch off the mind, being very irritated. Okay, being in a hurry, हमेशा घाय में, बहुत impatient. So these are psychological symptoms. Now they may present in the context of illness anxiety, where a person is very anxious, he may have a serious illness. That may in extreme present in panic attacks and this fear that I have a heart attack, they visit a hospital and things like that. It may present specifically exam anxiety, where a child, now boards are going to come, where a child otherwise is well adjusted, but just before an exam has something akin to a panic attack, has a blank out, cannot focus. So depending on what is the situation, what is the context, generalized anxiety would be more chronic anxiety running throughout the day, always worrying. Okay, it may come in the context of a diagnosis, like for example, there's a breast lump, you've just sent the woman for an evaluation, and the evaluation is that it's a benign lump, you send to a surgeon, you say, ki, theek hai, whatever. But now the woman has gotten into a thing, ki, do I have breast cancer? And she's getting into this constant, maybe I should go to a bigger doctor, maybe I should get this investigation done, maybe that, what if it starts? She's constantly reading on Google. So these are very, very common symptoms.
Which benzodiazepine is best for panic attack?
So panic attack, you want a short-acting benzodiazepine. You want an immediate effect. So alprazolam, clonazepam, lorazepam are our go-to things because immediately it will abort the panic attack. A long-acting benzodiazepine like diazepam or chlordiazepoxide will have a very slow onset of action. So the panic attack will not be aborted.
How do you manage aggressive, agitated patients in the clinic or during a home visit?
So there are 2-3 drugs that is nice to have at your clinic. One is injection lorazepam. One is tablet olanzapine. And another is injection Serenase and Phenargan. So Serenase, Phenargan, 1 ampule each can be mixed in the same syringe and can be given as a deep IM injection. It will reduce aggression in the crisis period. If you're called to somebody's house, a person, and without being very scared कि क्या side effect आने वाला है. If you are scared of giving one full ampule, you can just give half an ampule, it will solve the crisis. Again, lorazepam injection, because lorazepam is a short-acting drug, we are not very scared, and just IM can be given. Olanzapine is a very beautiful drug because it mixes in food without your having to पेशेंट को पकड़ो, कोई और पकड़े, बांधे, पेशेंट चिल्लाए, वो पूरा ड्रामा होने की बजाय probably it can be just mixed in juice or chai and be given to him. 10 mg olanzapine, maybe even 20 mg will be good to calm down a person, and olanzapine comes in preparations where it is a melt in mouth preparation, or it is a preparation that will dissolve in food without leaving any taste or something like this. So I think these 2-3 medicines we must read up: lorazepam, olanzapine, because whatever we write we should know everything about, Serenase, Phenarkin. And these can be given in an emergency situation without us being worried that a major damage will be caused. In fact, you will prevent some damage at that point of time. And then the patient can be referred. It will buy some time for the travel and for that.
How do you manage agitation in an elderly patient with Parkinson's or Alzheimer's disease?
So, elderly, we have to be very careful and cautious of benzodiazepine use. Lot of people will come to us saying that elderly not sleeping, agitated at night, din bhar achhe rehte hain. So this is the sundowning effect that we see in dementia, that it tends to worsen towards night. When we give a benzodiazepine, one is that we may cause falls in that person. The second thing is that that person may have a paradoxical reaction. So in a benzodiazepine paradoxical reaction, instead of a calming down, a person becomes all the more anxious, all the more agitated, may shout, may become aggressive. So person, you are expecting ki shant hoga, but you've induced a totally different reaction. This may happen in children and elderly. So these are two things we don't want, which is why benzodiazepine is best avoided. I think Qutipin is again a very good drug for this. Qutipin at a dose of 25 mg, and thankfully we have a tablet which is scored. You can start with half. Again, you have to inform the relatives कि जब ये toilet जाते हैं, go with him so that he doesn't have a fall. So basically, so Qutipin is a good drug for managing agitation in elderly.
Though we know we shouldn't treat schizophrenia, how does a GP suspect schizophrenia in a patient?
So some of the common symptoms of any mental illness are changes in behavior. That this person was an active person, suddenly stopped working. This person has stopped interacting with others, has become agitated, angry. So changes in behavior and personality. Changes in sleep patterns. That this person is not getting up from the bed all day, or is not throughout the night is pacing around. Then changes in appetite behavior, changes in grooming, like not willing to have a bath on a regular basis, has to be pushed to do things. Schizophrenia specifically, they show hallucinatory behavior. They may be talking to themselves alone when they are at night, or gesturing. They may have delusionary behavior where they may believe that people are against me, people talk about me, there is some plot against me. So they may have these false beliefs. Aggression, violence.
And ma'am, parents with schizophrenic children or children with some other mental illnesses, sometimes they push them into marriage or really want to get them married. So how do you do the psychiatric counseling in such cases?
So to be very frank, it is difficult because there is no right or wrong here. Does an individual not deserve to be married? Or what happens to the person who's getting married to this individual? So there's no right or wrong. Having said that, one of the things that we have to insist and tell the families that inform the samne wala party ki this person has schizophrenia. Inform, because otherwise it becomes a legal problem and you are liable for fraud. That is one thing. The second thing is that there are some initiatives, like a psychiatrist has started this website called manomarriage.com. He's an Aurangabad-based psychiatrist. So उसमें क्या है कि you upload the doctor's certificate, you openly share what is your disease, what treatment that you're on, and the doctor certifies that you're relatively fit to resume work, you're relatively fit to, because there's so many schizophrenics who are doing very well on medication, and they're doing their jobs, they're managing their families, and there are those who are not well. So, like in any other disease, you have people who respond well to treatment, and you have people who are resistant to treatment, similarly in schizophrenia. So those people should not be denied marriage. But the doctor uploads the certificate and then they are able to decide कि ठीक है, mutual consent say everybody knows that what is the condition and then they can go ahead.
4 minutes more.
Yeah, my last question, ma'am. So just like a GP treats hypertension and diabetes, do you think he or she should treat anxiety and depression too?
Yes. I feel that GPs should be aware of depression, anxiety, insomnia, medically unexplained symptoms, these 4 or 5 conditions. They should initiate treatment, and wherever the treatment becomes difficult or wherever they feel they are not equipped, they should refer. What happens is because GPs are not diagnosing, they don't feel confident, they don't diagnose. Once in a while when they diagnose, they refer patients say, no, we don't want to go to a psychiatrist, and they feel all the more dejected and they say, chalo chodo, हम वही handle करते हैं जो we are confident about. But I feel करना चाहिए, more patients will get treated, and also more will get referred to a psychiatrist because we will know what is working, what is not working. And across the world, it is the general practitioners who are treating majority of depression. If you go to US, UK, anywhere, Australia, New Zealand, all patients first go to a general practitioner, the general practitioner initiates treatment, and if required, then he refers a case to a psychiatrist.
Thank you, ma'am, for a wonderful, wonderful lecture.
I would like to thank both Dr. Kiran and Dr. Leena, and would invite Dr. Mahmood Merchant, our past president, to felicitate Dr. Kiran.
We would like you to felicitate Dr. Leena as well.